We're seeing patients younger and younger and early in the disease, but also we see a trend that, the very early patients are now more on the active surveillance trend. They're not treated. And we do see more patients with locally advanced disease, more aggressive tumors. And there's been kind of a paradigm shift that it's important in these patients to also treat the primary tumor. And here, then, if the patient undergoes radical prostatectomy, in many instances the question comes up, does the patient need additional radiotherapy? Now there's two ways to do that. Either adjuvant radiotherapy, and this per definition is when the PSA goes down to zero within the first 3 months after treatment, that would be a candidate, or salvage radiotherapy when the PSA goes back up again or when the patient does not reach zero PSA. It was an adjuvant study, and we have now long-term data with a 10-year follow-up. And so what we see is that in these patients, indeed, we have an advantage in the adjuvant radiotherapy group for progression-free survival, that is PSA progression. It's too early to have an overall survival statement because these patients have by and large a good prognosis. So the differences are minuscule, and few patients actually die due to prostate cancer in that setting. So this advantage is in association with other studies that show the same, like with the SWOG study or with the EORTC study. So in these patients, it's really, especially in those with a positive margin, it's an option to offer them adjuvant radiotherapy. PT3A, margin positive, consider adjuvant radiotherapy.